group, which we call a TSG, and he's going to speak on A5354. Oh, I have a new introductory slide. Oh, this is really important, right? Thanks, Judy. Judy, Dr. Perrier made this introductory slide. So we are each other. I think that's like, this is what this slide is about. And I think it's really important to remember. This is the overlap in ACTG and HPTN sites. So some of the people that were here over here on this part of Washington all week are actually now over at the JW Marriott because they're the site staff, the site PI, the site investigators. And you can see there are 8 U.S. sites, and I can't count that fast, but it looks like 12 or 13 international sites that are overlapping. So it's really, really important to remember that we are each other, and we're part of really our goal, our common goal to end the HIV epidemic through both prevention and treatment and to reduce comorbidities across multiple HIV-related infections and other comorbid conditions. Thanks, Judy, for making that wonderful slide. So anyway, Tim Wilkin is going to talk about the 5359 LATITUDE, comparing injectable ART to daily oral ART. Thank you, Tim.
Thanks, Joe. I'm happy to talk about LATITUDE. So in addition to achieving personal health benefits for everyone living with HIV, there's the public health benefits of preventing onward transmission. So 5359 really sought to look at ART, long-acting ART, in the setting of people who are experiencing challenges with oral ART. As everyone knows, the great success of the studies that led to the approval of cabotegravir and rilpivirine were all based on people doing quite well on oral medication. In fact, they were required to do well in order to be randomized to long-acting ART. So while it's great to have additional choices for people living with HIV, it really did not meet a public health need of achieving suppression for all. So the investigators for 5359 designed this study where they enrolled people experiencing viremia or challenges being retained in care, challenges with adherence, and enrolled them in a first step where they received oral ART as well as conditional economic incentives to support adherence. If they were able to achieve viral suppression, they were randomized to either long-acting cab rilpivirine given every 4 weeks or to be maintained on oral ART. As far as the study population, it represents the HIV epidemic in the US quite well. They enrolled 30% women, 5% on the transgender spectrum, 64% Black or African American, 14% with a history or current IV drug use, and the baseline CD4 was around 270. Additional data that wasn't shared at CROI for several social determinants of health. There were definitely some challenges in this population. Roughly about half of people were at or below the federal poverty line, 10% unstable or homeless, and really a number of social challenges for this group. And in addition, the group also was experiencing several mental health challenges. About a quarter of people were receiving treatment at baseline for a mental health condition, including about 30% of people who had moderate to severe anxiety or moderate to severe depression. As far as substance use, there was a fair amount of worrisome drug and alcohol use. About 30% of people had hazardous drinking, according to the Audit C, and a number of people with drug dependency, roughly half, with drug dependency or drug use related problems. And similar to many other studies with people with HIV, high rates of current and former smoking. As far as the study also implemented point of care urine drug use testing, and about 44% of people were marijuana users or had a positive test for marijuana at baseline, as well as about 20% were with amphetamine or methamphetamine, and about 37% testing positive for 2 or more drugs at baseline. So a high rate of ongoing drug use at baseline. And as far as the primary outcomes was regimen failure, which was defined as the first occurrence of virologic failure or discontinuation of treatment. This, as you know, was stopped during an interim DSMB or an interim look from the DSMB. So instead of a 95% confidence interval, at the time it was a larger 98.75% confidence interval since it was an interim look. And you can see that the primary outcome occurred far less frequently in the CAB-rilpivirine group with 24% as opposed to 38.5% in the standard of care. When you look at some of the secondary outcomes where you really start to see some differences, with virologic failure, six people in the CAB-rilpivirine group experiencing virologic failure as opposed to 28 in the standard of care group, a very marked difference. And this was supported by additional secondary outcomes as well, and really not much in the way of difference between permanent treatment discontinuation. As far as the reasons for permanent premature treatment discontinuation, it varied between the two groups. It's important to note that among the long-acting ART group, 8 of these 25 individuals actually never started long-acting ART due to other concomitant events, including incarceration, 2 deaths, pregnancy, etc. So taken together, CAB-rilpivirine demonstrated superior compared to daily oral standard of care ART in people with HIV in the US. The population experienced numerous barriers to adherence with prior history of virologic non-response or loss to follow-up. I think the team is really to be commended, at least for the ACTG. This was really our first large-scale trial in a population experiencing so many challenges. And they've demonstrated that that it is possible to conduct high-quality clinical trials, and we should continue this work. It also really changes the paradigm of how we use long-acting ART. Instead of really just reserving this for people who are already doing well on oral ART, we can take advantage of this directly observed therapy and really extend the long-acting ART to other populations. And I would suggest that the standard of care for people experiencing ongoing viremia despite oral ART would be to consider long-acting ART. And so with the ARTs, we do have additional work to be done. So our future long-acting ART plans at this point, we have planned or mostly conducted the protocol development for a study looking at long-acting CAB-rilpivirine in postpartum women who are at higher risk for virologic failure. This would be done at our sites globally. As many people know, the access to long-acting ART in low and middle income countries is unclear at this point. So hopefully we are all advocating for that. And what we've done over the years in the ACTG is to really iterate upon regimens to improve their efficacy, improve their safety and tolerability. And long-acting ART hopefully will be no different. So we want to continue to look at new combinations, new regimens to really maximize their success. And so we are hopefully starting development of looking at a novel combination of long-acting cabotegravir and lenacapavir as a pilot trial here in the US, sort of similar to the population that I just showed in 53-59, but really focused on those that either have NNRTI resistance or NNRTI intolerance. And ideally, if that's successful and we can engage the pharmaceutical collaborators, we want to extend that combination to our international sites as well, as this would be quite an attractive combination to study globally. And Monica will talk about some plans about investigating use of long-acting ART in people with ongoing viremia despite receiving TLD globally. And we've just started discussions about integrating long-acting ART into substance use treatment programs. And we had a really great symposium on that earlier in the conference. And we have already started talking to some of the investigators from HPTN 094 to learn about what seemed to work well in that trial, and looking forward to ongoing discussions as we trying to refine our scientific question about how to integrate long-acting ART into substance use treatment programs. And then when we look further into the next grant cycle, we really want to be strategic with our long-acting ART studies to really focus on the studies that will have the biggest impact on achieving the end the HIV epidemic goals here in the US, as well as the goals internationally. And we want to continue to change our model of how we conduct clinical trials to really look for more decentralized clinical trials, bringing the long-acting ART to the community, really different ways than we've been conducting trials to date. And so we look for ongoing collaborations with HPTN and others as we move into these new areas. So next, I'll introduce, you want to do it?
You've been so on time. Let me jump up.
Okay.
So this is remarkable for everybody who's been at this meeting. We're actually 10 minutes ahead of schedule, which is stunning. And I'm texting with Dr. Cohen, and that's always a thrill because he doesn't really know how to text. So you have to try to interpret it. So they would like to, so we can take questions, but first, Dr. Cohen and Mike and Wafa, I think, would like to try to say hello to see if the two-way street is working. So Mike, why don't I see if we can hear your voice? So why don't you give it a shot?
Well, now, can you hear me, Joe? Well, this could be the shortest Zoom.
I know that he said the sound was really good. He said the audio was really good.
Yeah, and on our end, this is great, I think. Can you hear?
Beautiful.
Wait, can you hear me? Can you hear me, Joe?
Yes.
All right, well, let's not try to make it too complicated. Good morning, Joe and Tim. Joe is a division chief at the University of North Carolina of infectious disease and one of the co-leaders of the ACTG with Judy Currier. Tim Wilkins is a leader at Cornell and did a terrific job just now with the talk. And as I understand it, so Wafa and I are here to try and help with this technology. As I understand it, what we're going to do is hear from Monica Gandhi and Susan Eshelman and then take questions. And what we'll try and do is if there are questions in our group, repeat them from the podium so that they can hear them there, and they'll do the converse here. And we'll see if we can make this. I think it's quite an amazing event. If we don't learn anything, at least we've done something entirely unique to the networks. So, and I do, by the way, I do know how to text. I just can't spell. Okay, so there's a whole interpretation group of anything I text. So that's a joke. Thank you for humiliating me. Thanks.
No, you love making fun of yourself, so it's okay. So I think what we'll do then is if people could save up your questions. I think there's a ton of questions for Tim. I know that the HPTN is very interested in kind of status neutral kind of testing and how we could cooperate in that and be the kind of treatment end. And so that, I think there should be a ton of questions. So please write them down because the way things are going, we might have a good amount of time for questions. So our next speaker is Monica Gandhi, who's a professor of medicine at UCSF and our antiretroviral therapy TSG vice chair, and really an expert in many different things, including pharmacology and also treatment in hardly reached populations. And she's also going to talk about integrase resistance and how to manage in less than perfectly monitored populations.
Well, thank you. It's really great to be here with the HPTN. And I'm going to talk about TLD as first and second line and surveys and risk factors for dolutegravir resistance, since that was the charge of this talk. And then a call by the WHO for more surveillance for dolutegravir resistance and maybe ways to triage and streamline how to monitor for dolutegravir resistance, including objective adherence metrics. So we all know that TLD has been first line for men since 2018, first line for men and women since 2019, and then since 2020 and 21, it's actually been second line in the face of NRTI resistance. And that was based not only on 2 trials that were performed prior to the approval of TLD, which was Sailing and Dr. Aaron's Viking study, but then later these 4 trials, the Dawning, Nadia, Vicend, and 2SD, all looked at dolutegravir versus a boosted PI in the setting of underlying NRTI resistance, either inferred or proven. And dolutegravir was either superior or non-inferior to the boosted PI in all of those trials. That 4th column, which meant that dolutegravir was approved as TLD2 for all people living with HIV, even if they had NRTI resistance. But I will call your attention to that last column of Dawning, Nadia, Vicend, 2SD, and focus in on that Nadia resistance data, which is that when failure occurred, there was about 4% failure with INSTI resistance in those who were receiving dolutegravir versus 0% failure with darunavir-ritonavir resistance in those receiving darunavir. So we already knew by this and other data that there would be cracks in the armor and that the resistance barrier to dolutegravir is not impermeable. So what does lead to failure on TLD? The majority of it is having a hard time taking those medications every day, which happens in the US, it happens everywhere, a lot of stigma worldwide. And the 5381 that was presented in yesterday's plenary session from the ARTS TSG was a really good example of actually looking observationally at the rollout of TLD as first-line therapy and showing that really the majority of failures that occur are because of inadequate adherence, with proof of that from objective adherence monitoring. So that is the majority of TLD failure. But there is, 6 years into the rollout, some resistance starting to emerge. And the WHO reported in 2022 that already just after 3 years of the rollout of TLD, 80% of those living in low and middle income countries had transitioned to TLD. Massive numbers of people are on TLD, probably estimates around 24 million people worldwide. And if you have that and a little bit of resistance possibility, then you're going to get into some resistance developing. And the WHO resistance report that came out in conjunction with the CROI meeting in March shows and surveys maybe around 4 to 8% resistance, but we'll dig down into that a little bit deeper in this slide. So now, if you look at the surveys that have been done of dolutegravir resistance, some patterns are emerging. Again, it's low, but there are certain risk factors for developing dolutegravir resistance. One is underlying NRTI resistance. One is having extensive treatment experience in the past. Other, of course, is using dolutegravir dual or monotherapy. Having a persistent ongoing virologic failure on TLD, never suppressing. That ongoing viremia is a risk factor for resistance. Starting TLD with viremia, this is just a recent CID paper this month in Malawi and Namibia, does look like there's more resistance if you start with viremia than being suppressed. Of course, prior experience with former INSTIs children are more at risk for having higher levels of resistance than adults. And then, as the next talk will show from the HPTN with Dr. Heshelman, breakthrough on CAB-based PrEP, of course, will lead and can lead to INSTI resistance. So there's not a panic, there's an awareness. And that just means that when the WHO put out their resistance report, they have really called for an increase in surveillance for dolutegravir resistance. This needs to likely be, and it will likely be rationed because resistance testing is expensive in low and middle income countries. It's expensive everywhere. And although there are absolutely ongoing and interesting work about developing point-of-care HIV drug resistant tests, we don't have those yet. So the next question is, how can we economically triage resistance testing and still get to where we need to go in terms of surveillance? So that is the next question, is are there ways to ensure that you have a population that's enriched for the likelihood of resistance when you send someone on for resistance testing? So I think that there is going to be a role here for objective exposure monitoring. And that's actually a very simple concept. If you have no exposure in your drug at all because you are not taking the drug, you don't have selective drug pressure to evolve resistance. It's really in the case of having off and on adherence or having some exposure to the drug that will be that risk factor for developing resistance. So the concern is actually having a high viral load and an adherence metric that's showing you're taking the drug. That's the yellow box. That really signals a possible resistance problem, and it's those patients that you want to triage for resistance testing. Having a high viral load, low adherence, that's your adherence problem. Having a low viral load, low adherence, that's a problem for the future, and you need to counsel. And of course, having a low viral load and high adherence is exactly what you want. So what evidence that we have, evidence do we have for that? That objective adherence monitoring and showing that you have the drug in your system is going to lead to a population that's enriched for resistance. Well, this was an important study that was at the 30th International Workshop for Resistance and Treatment Failure in September in Cape Town, which looked at people who were failing therapy in South Africa and specifically did drug level testing, did what's called liquid chromatography tandem mass spectrometry to look for drug levels in their blood. And in those who had dolutegravir in their blood on TLD, the rate of resistance was 11.9%. It was up from 2.7% just the year before. So this was 2022, 12% resistance in those who had dolutegravir exposure. So that's your other risk factor for developing dolutegravir resistance, is having, of course, exposure. And the South Africa treatment guidelines have now gone so far, as of a year ago, to say that we are going to only do resistance testing in this country for those who have an objective adherence metric that shows that you're taking your drug. So what the algorithm is on the right side in the guidelines is that you have to be on TLD for 2 years, even though many provinces are doing just 6 months, and have 2 elevated viral loads. And then you have to document an objective adherence metric that shows drug exposure before you pass on to resistance testing. The 4 that are mentioned in the guidelines are either a dolutegravir test by LCMS in the blood, a tenofovir diphosphate test in dried blood spots, a urine tenofovir assay, or looking at pharmacy refill data of over 80%. They also have clinic visit attendance of over 80%, but no one thinks that is necessarily a marker of adherence. And in fact, Dr. Graham Medinci's has shown some data that if you look at just this enriched population, the rate of resistance is up to 57% in that triaged group. So how do we measure adherence? What should that objective adherence metric be? Absolutely, there are subjective metrics, including self-report, but they have proven to be they can be unreliable because of social desirability bias and remembering. The more objective measures are really measuring drug level in the system. That really proves that you've taken the drug. Pharmacy refill data in a closed system can be quite reliable, and that has been put as an objective adherence metric on the South Africa guidelines. And then electric monitoring and sensor devices, there are some more expensive research tools. In terms of adherence measures, the most objective is the cheapest, which is just asking people if they're taking the drug, but again, it can be biased. And then you go up in terms of expense and more difficulty to perform all the way to directly observed therapy. And in between are the pharmacologic metrics, which is really measuring drug levels in urine or blood or dry blood spots or some matrix. And of course, it proves that you've taken the drug. Pharmacologic metrics have been really important for adherence for more than 12 years. It was really the FemPrep and VOICE trials that showed us that self-report, return pill counts can be high, but by tenofovir detection, by drug levels in both of those trials really showed us that women in those randomized controlled trials were not taking the active drug, or they were about a third of the time. And it was really, that really launched the field of objective adherence monitoring and made it where it is right now. So each objective adherence metric, or at least pharmacologic drug assay, gives you drug level exposure over certain periods of time. Plasma and urine are short-term metrics of adherence, and dried blood spots and hair levels give you exposure to the tenofovir, in this case, over longer periods of time. So all of this to say is that we want a drug level assay. It'd be really helpful in triaging resistance testing, but we want one that we can do right away and isn't very expensive. And so various groups set off to look for a point of care drug level assay, including our own. And what really allows you to do point of care testing is an antibody-based test, as opposed to using a very expensive liquid chromatography tandem mass spec machine and processing the sample. You want like a urine pregnancy test or a SARS-CoV-2 antigen test, something that you just dip really fast, but you really need a selective antibody to the specific compound. In this case, it would be tenofovir. So we worked with a drug company, Abbott, for many years actually, to develop a very highly selective antibody to tenofovir as the main drug in ART and PrEP, and did come up with a highly selective antibody, and actually did a lot of validation work to show that this antibody is very selective. It doesn't pick up anything else in the body, like endogenous nucleotides like adenosine. It's very selective just for tenofovir, and we really compared it and did that work against LC-MS. So now this is what the urine test looks like. It's pretty simple. It looks like a pregnancy test. It's first generation. When they eventually market it, it'll be more obvious and maybe a plus sign or a smiley face or something for taking the tenofovir, like a pregnancy test. So that's to say then that what is this urine test? How could it be helpful in terms of the resistance screening? Well, we do know in the setting of PrEP that using the urine test and counseling, and this is really relevant to the HPTN, counseling in the face of looking at a urine test, because you don't have a viral load test in the face of PrEP, does increase long-term adherence. This was a study that we conducted in Kenya and just published in the Lancet HIV, and it just shows that in these women in Kenya who are taking PrEP in non-serodiscordant partnerships, showing them the urine test and counseling on the urine test, as opposed to a randomized arm where the urine test wasn't involved, did increase both short-term adherence by the urine test, but also important long-term adherence by hair levels. And that was helpful to show that there likely wasn't a white coat adherence effect, meaning it wasn't just a transient increase in adherence. The hair levels really showed there was a longer-term increase in adherence. And then I showed this data before at this meeting from the CDC intervention that we did in Namibia, which is people who are not on TLD, who are not virologically suppressed. This is not randomized. We're doing a randomized study now, but this is a pre and post intervention. People who are all failing TLD, using the urine test to inform the enhanced adherence counseling, and virologic suppression did increase by 3 months to 87%, and actually was sustained at 9 months at 97%, and that went on for longer even after the intervention stopped being applied. So that was helpful, and a lot of providers and a lot of the people in the study actually liked the urine test, and we do very non-judgmental motivational interviewing around the test, and did a lot of formative work to make sure there was no judgmental messaging when it was negative. And then there are 3 studies now with our test in 2 and with another test in another study that shows that indeed the urine assay does predict resistance, at least with NRTI-based regimens, and with dolutegravir, but that was specifically to the NRTI in the regimen. So these were studies from Uganda and South Africa that if you have a detectable urine assay and you have a high viral load, that's the setting in which NNRTI resistance, there's a very high predictive value for NNRTI and NRTI resistance. So the final slide is that I'll end with this proposal, which has not actually been applied yet. So this would be a really interesting thing to do in the ACTG because observational studies have been done, like the Hakim study, and maybe this could be layered on the Hakim platform, which is to take people who are failing TLD. Again, it's 2 high viral loads. I think should be the criterion in, at least in South Africa, it's 2, not 3. Being on TLD for at least 6 months, I think that's the right number. And then if there's elevated viral loads, doing the urine test, and then essentially not just triaging for those who have a positive urine test, but actually looking at the prevalence of resistance in those who have a positive urine test versus negative urine test, and seeing if it's enriched in those with a positive urine test. And then looking for INSTI resistance that way. And I'll end, because this was not the charge of this talk, but we have talked about it at the meeting, is the possibility in the ARCH TSG of our kind of aspirational trial that taking these 2 groups, those who are INSTI resistant, those who are INSTI sensitive, to then move on to either adherence interventions in each of the groups, when we randomize to staying on oral therapy, either TLD in the susceptible group or darunavir in the resistant group, versus another arm with long-acting ART that is tailored to the resistance pattern for those individuals. And that is really our hope for an eventual trial. So thank you so much.
Thank you, Monica, and thanks for staying right on time. That's beautiful. So Mike and Wafa, we'll turn it over to you to introduce Susan Eshelman.
Yeah, thanks. But I guess I want to see myself on the screen, not to yeah, yay, not to be too got it. I look really bad today. On behalf of Wafa.
Yes. So give us 1 second to make sure you show up.
Okay, thanks, Joe.
Oh, there you are. Then there I am.
This is a modern technology miracle. On behalf of Wafa and I, we really are excited about doing this. It's actually fun. Joe, do you have actually humans in your audience? Yes. Okay. Because we don't know. We can't see your audience. So because it all could just be just Joe and Judy, and Tim. Could be a whole like Potemkin village kind of thing.
They all came from the street.
Okay, let's get started. So Sue Eshelman is well known and beloved to our group, is directing our lab center. She's worked pretty tirelessly on kind of uncovering the strengths of CAB-LA were demonstrated beautifully in the last 2 talks, really. Exciting use in the treatment space. Sue, in the prevention space, has really done a great job at uncovering potential limitations and challenges, and she's going to talk to us about that right this minute, I believe.
Thank you very much for the opportunity to meet with you today. I'll be talking about integrase strand transfer inhibitor resistance in...
Go close to the microphone. You got to put your... Try it again.
Hi, everyone. Thanks for the opportunity to meet with you today. I'll be talking about integrase strand transfer inhibitor resistance in the setting of CAB-LA pre-exposure prophylaxis. As we know, long-acting injectable cabotegravir, or CAB-LA, is highly effective for HIV prevention. And in this presentation, I'll provide an overview of the data we have on HIV drug resistance in persons who acquired HIV infection in the setting of CAB-LA PrEP. A lot of our research has shown that it can be very difficult to detect and confirm infections in the setting of CAB-LA PrEP. And this makes it more likely that drug resistance will emerge before infection is confirmed and treatment is started. And I'll show you in HPTN 083 that most participants who developed resistance to CAB-LA had cross-resistance to other drugs that could potentially impact their response to INSTI-based treatment. The goal of this research is really to, if we understand drug resistance in the setting of Cabolet PrEP, I think this will help guide recommendations for treating people with Cabolet PrEP breakthrough infections. So for those who aren't familiar, HPTN 083 and 084 were randomized clinical trials that demonstrated that Cabolet was superior to daily oral TDF-FTC for HIV prevention. And the data I'll be showing you today is from HPTN 083, which enrolled men who have sex with men and transgender women in the US, Latin America, Africa, and Asia. To date, we have not reported on INSTI resistance among cisgender women who were enrolled in Africa in HPTN 084. Cabolet was approved for HIV PrEP by the US FDA in December 2021, and it's now approved for PrEP or pending approval at many countries globally. This slide shows the schema that was used for CAB administration in the CAB arm of the two trials. Participants first had 5 weeks of daily oral cabotegravir in an oral lead-in. They then had 2 injections a month apart, followed by injections every 2 months for about 3 years. After that, they transitioned to oral TDF-FTC. HIV testing performed at study sites included an RNA test within 14 days of study enrollment. And then rapid and antigen and antibody tests were used at enrollment and at follow-up visits to screen for HIV infection. Once the studies were unblinded, participants continued in their randomized study regimen while waiting the open-label extension study, or OLE. In the OLE studies, participants could choose oral TDF-FTC PrEP or Cabolet PrEP, and HIV viral load testing was added at every study visit for HIV screening. A key point throughout this presentation is to understand how rare HIV infections are in people using Cabolet PrEP. This shows the number of infections and different types of infections detected during the blinded phase of the trials, plus the first year after study unblinding. And the key point here is that with almost 8,000 person-years of follow-up, we only detected 6 infections in people who were infected despite receiving on-time CAB injections. So the infections are rare. By characterizing these infections in great detail at the HPTN Lab Center, we determined that HIV rapid tests and antigen antibody tests often failed to detect infection in the setting of Cabolet PrEP. Profound viral suppression and delayed or diminished antibody expression can persist for months after infection, even after injections are discontinued, and this reflects in part the very long half-life of the drug. Delayed detection of HIV infection can lead to unnecessary Cabolet injections and delayed treatment initiation, and this has the potential to impact personal health and ongoing transmission. It also, as I'll talk today, can lead to emergence of INSTI resistance. We coined the term long-acting early viral inhibition, or LEVI, to describe the biology and lab features of early HIV infection in the setting of long-acting PrEP agents. So in this study, in both trials, we've been evaluating HIV drug resistance, and this testing was performed retrospectively, and I'll be presenting data from the blinded phase in the first unblinded year of HPTN 083. Samples with viral loads over 500, which is the usual cutoff for genotyping, were tested with the GeneAssure Prime assay at Monogram Biosciences. Viral loads below that level, those samples were tested with a low viral load single genome sequencing assay at Lou Halvis's lab at the University of Pittsburgh. And genotyping results were interpreted using the Stanford HIV drug resistance database. Overall, we detected major INSTI resistance mutations in more than half, 10 of 16 cases, where the first actual HIV positive visit was within 6 months of a CAB injection. And this included all 6 cases in persons who were infected despite on-time injections. Major INSTI resistance mutations were not observed when the first HIV positive visit occurred more than 6 months after CAB administration. And I'll just add a note that this timeline may be longer in cis women due to the longer terminal half-life of the drug following an injection. one thing we noticed early on was that INSTI resistance emerged very early in this setting, even though the viral load can be very low. The major resistance mutations, the median number of days after the first HIV positive visit to the appearance of a major INSTI resistance mutation was only about a month. And at that time, the median viral load was 148 copies per mil, which is well below the level that's routinely required for HIV genotyping. And our prior publications show that retrospective testing with a sensitive RNA assay did detect the infections much earlier than rapid tests and fourth-gen assays, and almost always detected the infections prior to emergence of INSTI resistance. The so-called missed HIV infection did provide an opportunity for selection and accumulation of major INSTI resistance mutations, as I'll show you. This slide just shows an overview of the 10 cases we've characterized where we detected major INSTI resistance mutations. And I'll say in this slide and the subsequent slide, we also detected accessory mutations which contributed to predicted drug resistance, but I'm not showing them here. And here I've color-coded each of the different types of mutations with a different color. And the point is just to show you that there's no single pathway to the emergence of INSTI resistance. Different mutations emerge first and accumulate in different orders and combinations. Of these 10 people, I'll note that 5 were started on darunavir-based treatment and 4 were started on efavirenz-based treatment. Only 1 was started on DTG-based treatment, but that treatment was not initiated for several years after the infection was detected, and we don't have outcome in that case on a clinical treatment outcome. I'll show you a series of slides like this. This shows data from these 10 cases, and it shows on the x-axis the number of weeks since the first HIV positive visit. In this shows the blue arrows show, the x-axis is 0. That's when the infection was first documented by retrospective testing. And the blue arrows show the time at which the site first detected the possibility of infection. And in all 10 of these cases, rapid tests and antigen antibody tests that were used for screening failed to detect the infection at several visits. I'm sorry, because some of the lines on the graph don't appear on the slides. I'm not sure why. In all 10 cases, the delayed detection of infection meant that additional cabotegravir injections were given after the person was infected. That's shown by the little orange syringes. This slide shows the predicted integrase strand transfer inhibitor resistance at the actual first HIV positive visit. And I'll note that in these 10 cases, there were 7 that had viral loads below 500 copies per mil, and even so, 2 of those failed testing. We had results for 8 cases. We had genotyping result for 8 cases at the first HIV positive visit. And in 2 of those cases, shown by the red dots, the participants had high-level INSTI resistance, and in the other cases, the green dots, they had susceptible virus. This shows what happened by the time the site detected the possibility of infection, the blue arrows. By that time, 3 of these people still had viral loads below 500. 1 was too low to be tested. We had genotyping results for 9 of these cases, and 8 of 9 had high-level INSTI resistance, shown by the red dots. So in the time it took between the first documentable infection from retrospective testing to the time that the site detected the infection with routine screening assays, these mutations, as well as accessory mutations, emerged. So that's general predicted INSTI resistance. Furthermore, in 4 of these cases, we found additional major INSTI resistance mutations at other visits. So overall, in all 10 of these cases, there was evidence of high-level INSTI resistance at 1 or more visits. This shows the predictions for dolutegravir resistance based on the same mutations. At the first HIV positive visit, only 1 sample had evidence of predicted DTG resistance. That's sample D6, D5, shown by the orange circle. But by the time the site first detected the possibility of infection, 5 of the samples had intermediate predicted dolutegravir resistance, and 2 had predicted high-level dolutegravir resistance. Those are the red dots. So overall, major INSTI resistance mutations were detected in more than 1/3 of all of these cases of infection, And in more than half, 63% of the cases where the first HIV positive visit occurred within 6 months of a CAB injection. They were also detected in all cases that occurred with infection despite on-time injections. And in 8 of the 10 cases, there was prediction of intermediate or high-level dolutegravir resistance. We also note, again, just to highlight, the resistance often emerged very early when the viral load was too low to assess with standard genotyping assays. So this is more of a challenge in a clinical setting where you may not be able to assess resistance using standard methods because the viral load is too low. So the key point here, as I said at the start, is that HIV infection is rare in those receiving on-time CAB injections. But that because of the profound viral suppression and delays in antigen and antibody production, it's often not possible to detect these infections using standard screening assays. And the delayed detection of infection using this type of screening does allow for accumulation of INSTI mutations with increasing resistance over time. And clearly further research is needed to assess the response to INSTI-based ART in persons who acquire infection in the setting of CAB-LA PrEP. So I'd like to thank the collaborators for all these studies and the labs that participated, and our funders, study teams, and participants. Thank you.
Thanks, Sue. I think now we're going to try and see if we can do questions. I don't think we can have video so much as just, can you hear Joe?
Yep, we
Okay.
can hear you fine, actually.
Okay, I have a question for Monica. First, great talks from both Tim and Monica. My question is the kind of frequency of the Integrase. I must have missed it. Like, how common is the problem you're searching for, Monica? Like in this setting, can you repeat that? Like what the frequency is in your last slide?
Yeah, she can hear you just fine. Monica can hear you
Yeah,
fine.
the question was, how frequent is dolutegravir resistance? It actually is kind of all over the place because it depends on the study population and the survey that's been conducted. So there is a large ongoing dolutegravir surveillance going on in Ukraine, Uganda, Malawi, and Mozambique. And in Uganda and Malawi and Ukraine, actually, it's between 4 to 8%. So 4 to 8%, everyone is failing, of course, by definition, therapy, and about a 4 to 8% resistance. In Mozambique, when this is all in the WHO report, the rate of resistance was actually 19.6%, but it was the difference between Mozambique and those 3 other countries in that surveillance report is that the clinic-based population they looked at were all highly treatment experienced. They'd been on efavirenz, TDF-FTC before. So it really depends on what your denominator is, what the proportion of resistance is. It's enriched in people who have treatment experience and who have ongoing virologic failure and who have off and on adherence and who have exposure. And then in the general population, I think the rate can be, let's maybe use something like 3%.
So let me ask a follow-up question.
But Mike, let me clarify that because it's kind of similar to what Sue showed, Eshelman, right? If you look at people who fail cabotegravir for prevention, it's 8 out of 10, or maybe it's 9 out of 10, so it's 90%. Oh my God, right? But if you look at the denominators from those studies from Uganda and Zambia and Malawi and South Africa, the denominators are in the tens of thousands. So I think I think what Monica said is 100% correct. In people who are failing, who have enough viral load to get a resistance test, that you see approximately anywhere from 4% to 20%. So and that's why it's so critical to do what Monica actually suggested, which is figuring out in people who are failing who should actually be resistance tested, because that percentage goes up. The more likely that if you detect drug like tenofovir, then the percentage actually even gets higher, which is actually parallel to what Sue showed, because everybody has cabotegravir exposure, and if you have the drug present, you get that selection. So that and the denominators of those studies are imperfect at best. the big denominators, like the 15,000 and the 20,000.
So let me just ask a quick follow-up, Monica, and that is, so in your last slide with the algorithm, essentially, what percentage of people you started on TLD are going to have high viral load on TLD? That is, how much will people be coming to the clinic and need what you're suggesting they need? I get what you and Joe said, and I'm just curious about, is it going to be 1 out of 10 people are going to need this kind of algorithm, or is it 1 out of 100, or is it 20%? I have no idea the frequency in which you expect to apply the algorithm.
Yeah, that's a really good question because it definitely depends on the setting. For example, the virologic suppression rate in East London, which is, more rural area, Cape Town is 62%, and the virologic suppression rate in Cape Town, Western Cape proper is 95%. So it really depends on the setting. UNAIDS looked across large numbers of countries, and the virologic suppression rate is about 71% on those who have HIV. So it really depends on the setting. But say, to give the question of prevalence of resistance in those who are virologically suppressed, it's profoundly low, it's probably 0. And then those who are persistently failing and have drug exposure, that's the population that's enriched for resistance, and that's the population you want to send on for testing. So that's why the South Africa treatment guidelines very wisely said you can't actually get a resistance test if someone said they're not taking their drug or they don't have drug exposure. Just please counsel them, adherence counsel them. That's what you should be doing.
Okay, Wafa has a comment to make, so Wafa, hold on 1 second. You have to press the button.
Can you hear me?
No, press the...
Oh, thank
Okay.
you. I think there are data from the population HIV impact assessment, the FIA surveys, which are national surveys that were conducted in several sub-Saharan African countries. And this is a representative samples of these populations looking at exactly this question because in addition to HIV testing for individuals who participated in all the households that were sampled, for those who are HIV positive, they had viral load, and also they had ARV detection in their blood, Monica. So it offered exactly the opportunity to look at the question of what percent of those who are unsuppressed were virologic failure versus non-adherence. And the early analysis showed that the vast majority were due to non-adherence, and virologic failure was, in this nationally represented sample, was quite a small percent. So I think we're going to learn from surveys like this in terms of what's the proportion of virologic failure versus the non-adherence, and exactly the denominator we need to do the resistance testing in.
Okay,
Thanks.
thanks. Let me, you have a comment to make, Judy, and then we're going to move on.
Yeah, Judy has a comment, yep. And then,
It's a different topic, so.
so
it's
let
not
me
that,
let me also say that where there's as far as I know, a kind of a complete data void is, and I don't know, Dan, I can see him out there, he may know, is how transmissible NNRTI from a public health perspective, right? We know that transmission is very different, right? If you look at 2 of our most common mutations, 103N and 184V, 103N is very commonly transmitted, and then is transmitted, it persists in the population because it has almost no fitness hit. So you don't have to be exposed to a person on efavirenz to get an efavirenz resistance mutation. On the other hand, 184V is uncommonly transmitted. It can be for sure, but uncommonly. So I think it's a complete data void. I don't know, Dan, if you know whether it is transmissible. There are case reports of transmitted and INSTI resistance, but.
I think you characterized it correctly, Joe. It is a data point. There have been a very small number of case reports of transmission of INSTI resistance, but it's not become the problem that we saw with transmission of NNRTI resistance when there were high levels of NNRTI resistance, especially, for example, after use of single-dose nevirapine for prevention of mother-to-child transmission and so on. And we know that the 263K mutation renders the virus highly impaired in terms of its replication capacity. Would be surprised, even if transmitted, if it persisted and didn't revert or get replaced by wild type. So it's an important question to be addressed.
So then Judy and Mike, we have a person at the microphone.
We got 2. Let me, because you're sitting, Judy, let me ask one of the microphone people want to say, so is that okay? Because they're standing for a long time. So Sunil, this is Sunil Solomon asking you a question of somebody.
Yeah. So we'll alternate. You go, Sunil
Yeah,
goes,
and then Judy,
and then
yeah.
Nilu goes.
Okay.
Great. We're doing the best we can.
Am I audible? Okay. Tim, great presentation, and I think Adia, Rafi, the entire 53, 59 team have to be commended. The individual level benefits, Joe, as you mentioned, undoubtedly clear, but the whole INSTI resistance and the transmission, I guess this is for both Sue and for, so you had like 20% of the people who didn't meet primary endpoints, so either got one injection and they never were seen again. And so you're looking at people who have drug in their system, and if you're looking at it from a public health standpoint, from what you're saying, it looks like 184V and regular oral INSTIs have very short half-lives, but CAB is going to stay in your system for so long. So what is the risk of picking up INSTI resistance and transmitting INSTI resistance to someone else? Because globally, TLD is the only drug we have. And if we lose that, all the case reports that Sue showed, they were all like on protease inhibitors. And I guess the second question for Mike, Wafa, Joe, and Judy is like, would there be interest in looking at a simplified version of Latitude, because Latitude was very complicated to get people on that long-acting, and then marrying that with HPTN 052 to look at the treatment as prevention benefit in people who use substances globally.
Okay.
Go ahead, Tim. I think that's you.
I guess, Tim, this is,
To address your later question, yes, I think everyone involved, including the terrific 5359 team, would be supportive of strategies that start with long-acting while viremic, much direct to inject, much simpler than the design. That study remarkably started before the approval of rilpivirine, so of course it was much more cautious. Yes, the people who received long-acting rilpivirine who left the study or were lost to follow-up, there is concern that many of them would have developed resistance to both NNRTIs and Integrase. And as we previously discussed, we don't know how commonly that's transmitted.
Yeah, but we do know in the study there were two, correct?
There were two actually in the standard of care arm and two in the long-acting ART arm that developed new resistance mutations. So it was relatively uncommon and incredibly outweighed by the benefit for viral suppression and immune reconstitution.
But to address your latter point, Sunil, that very last question about a status-neutral approach to those who use substances and randomizing to CAB PrEP versus CAB rilpivirine, that is really an exciting idea of collaboration.
Yeah, so we're gonna, it's our turn, and Nilu's at the microphone, and we have other people at the microphone, but we will alternate. This is great. Can I make I want to make a public service announcement though, especially to our HPTN colleagues. The ACTG has a study, 5321, that is actually looking for people who became HIV infected while taking cabotegravir for prevention. And the idea is to study those people because they likely have very low reservoir. And this is in collaboration with Rafi, who, like many of us, sits in two houses of both the PTN and Rafi Landowitz, the PTN and the ACTG. So Nilu, you're up.
Hi, my question is for Sue. For those individuals with the breakthrough infection with PrEP, could you just comment what was happening to the CD4 counts, and have you looked to see if there's any evidence of primary antibody or T-cell responses, and was that sort of level of breakthrough enough to
Sue, did you hear
detect escape?
Did you hear the question, Sue? This was to you about your cohort, about the clinical follow-up of the people that you've discovered that had been exposed to cabotegravir and then were recognized to have infection. Do you know much about their viral load, their CD4 count, their immune response? I think you do know a lot about their antibody response, so I don't know about the rest of it. That's Nilu Gundakalaki, I think, was asking the questions. What else you might know about
If I understand the question correctly, we do not have CD4 count data on these folks. We did, so long as they were followed in the trial, determine their viral loads and follow those with and without treatment, whether treatment was started or not. And we did follow them until they had a positive discriminatory test in terms of antibody expression, though we did have cases, few, where a year after infection, the discriminatory antibody or genius test was still not positive. So we know that the delay for antibody expression can be, really prolonged, profound. And the viral load often remains low for very long periods. In our one of our more dramatic cases was a case in HPTN 084, where a woman who clearly was infected had acute infection at enrollment that was missed with the RNA screening assay, went on to receive Caballet PrEP, and then her viral load went to very, very low levels, and then was not detected even with John Miller's single copy RNA assay. It was below 1 copy per mil for 6 months on injection, and for 6 months even after the injection stopped. So we know that the level of viral suppression can be not only profound, but really, really prolonged even after injections stop. So we have this data for all of the cases, in addition to the cases I've described here, which are only the ones with resistance.
So her question, though, is if we had access to these people in 083 and 084, her question is, what was the cell-mediated immunity in the setting of this subclinical, and it's an interesting question because, she studies cell-mediated immunity, so maybe these people can be refound at some point.
We didn't measure cell-mediated immunity.
So Mike, I think this is the point of this study that 5321 group 6 is to do a more thorough characterization of the immunologic responses of these really interesting early seroconversions. So.
Thanks, Judy. Is it our turn now?
Keep me enrolled.
So it's your turn for a question.
Okay, this is Sten Vermund, Professor Sten Vermund from Yale University.
All right, thank you. A question for Tim. In the LATITUDE study, persons were paid, and there were a lot of comorbidities, social, mental health, substance use, and you were very successful at follow-up and answering the core question of efficacy. If we translate this into clinical practice in Ryan White supported centers, in overseas venues where we're not paying individuals, can you speculate as to, based on your experience from LATITUDE, is really the payment something that's essential for the folks with such substantial comorbidities, or was the injection strategy so appealing that people were happy to come back anyway?
Yes, so how the protocol team has put this together is that the conditional economic incentives, the larger payments, were really to achieve viral suppression on oral ART. Those stopped once people were randomized. So the conditional economic incentives did not extend into the long-acting ART phase. Now, being in a clinical trial, the extra support, the stipends, reimbursement for transportation, I think was more standard. So I don't think that was the driver. I think it really was the access to the long-acting ART.
We have about time for one more question. Let me first give my greetings to my good friend, Dr. Sane, who is a silent partner in this. So good morning, Dr. Sane.
Good morning.
Good morning.
So we have a couple people at the microphone.
Okay,
so,
you go out and do those two.
You
and then.
guys could please identify yourself and try to ask a quick question if you can, so we can get everybody who's in line a chance to ask a question.
Okay, Lionel Hillett, CSS, and ACTG representative. I'm just talking about observation. I noticed that the young lady said they were doing one-on-one with individuals and they were not judging. But I know throughout this whole process, a lot of stigmatizing language has been used. The word infected has been used hundreds of times, and when it's referencing an individual. So I just want to bring that to individuals' attention.
Yeah, thank you for that. I just want to remind people that DAIDS released their policy on use of language, so I think that's something that all of us should review and work better to use non-stigmatizing language. Certainly that's our intent.
Thank you, Tim. Niru has a quick question.
Yeah,
Niru?
Thanks.
Your
Niru
turn.
Sista, I have a quick question to Monica. Do you have any insight about why participants improved their adherence when viral load and point-of-care urine tests for adherence was shared? Do you think it was because they understood the correlation between taking the drug and viral load suppression, or was it more fear of being called out? Do you guys do any kind of further analysis?
Thank you so much. We did some qualitative interviews, and it looks like it just feels it's very positively reinforcing to take a medication and then see that it's in your system, because it feels like you're doing something kind of right by your body and the body shows it. So there was a lot of positive motivation to seeing that something was showing up, I think, in your body. And that it was so, and then, yeah, they're probably, this is another study by Renee Heffron and her team, but it could be that people also, know that there's going to be drug level monitoring, so keep on taking the drug. That could be a part of it.
But it is consistent with the point of care viral load data that seems to engage people in care and promote adherence.
Go ahead.
Your turn, Joe.
Okay, thank you. My name is Sandile from the community. My question would be short, straightforward to Monica. Thanks for the presentation. But your presentation bring fear and the hope, because I'm coming from South Africa. One of the expectations from a DTG-based regimen was the issue of suppression and the issue of the price, which was more cheaper than equivalence-based regimen, and also to ensure that we maintain more people on treatment. But what will be alternative, the potential alternative, if we are failing on DTG-based regimen, because we make lots of hope based on DTG-based regimen? Thank you.
Actually, I feel like it's not a time of panic, at least at the WHO level, about the low levels of dolutegravir resistance. It's about trying to surveil for it and ensure that we get the right populations to send for resistance testing. But there was a real feeling that, and I think the 5381 really shows this, is that TLD is working great 6 years in. It's really potent. It has a really high genetic barrier to resistance. And that adherence interventions are also an incredibly important thing when life is hard and it's hard to take those pills every day. So I think we are not, I don't think anyone should be feeling too unhopeful about this relatively low rate of resistance 6 years in.
Thank you, Mario. Last question will be this. Introduce yourself, please.
Good morning, everyone. This is Nyaradzo from Zimbabwe. So thank you to all our presenters. Great presentations. I've got one quick question for Sue. The 6 on-time participants who had resistance, did you stratify to check whether they were primary or they were transmitted? Number one. And then number two, maybe to Susan and to you, Monica. Is it a fair assumption that, especially in our locality where we've got cisgender women who are now on cabotegravir, if they do become HIV infected, is it a fair assumption for us to start them on INSTI-based regimens, because we've rolled out TLD in Zimbabwe and other African countries? So is it safe? And would we stratify between men and women, men on INSTI-based regimens, and then women rather, and then men on maybe PI-based regimens? So I hope my questions are clear. Thank you.
Okay. So in all of the cases where we were able to get genotypes at the first HIV positive visit, in almost all of them there were no INSTI resistance mutation, indicating that they were almost certainly acquired from drug exposure. I think transmitted would be far more likely.
Okay.
In terms
I mean,
of
far less likely. Very unlikely that they were transmitted in this setting. But they were documented to be wild type earlier.
But in terms of your second question, it's such a good question, because if HIV is acquired in the HPTN 084, as Dr. Eshelman just reviewed, there were no people with HIV who developed resistance to the INSTIs. It was in the HPTN 083 and blinded, which is men who sex with men. So I think it's really important to say that the women may have higher drug levels, which have been alluded to and has been shown by other studies, and that higher drug levels may hopefully preclude that development of resistance. If they're less likely to develop resistance, it does seem like you can try TLD with women who seroconvert on CAB-LA PrEP, but I think it has to be looked at.
Sue wants to add to that.
I just wanted to say that I've only presented here the cases that have been reported to date previously. first, but also 084 enrolled fewer people and was unblinded with shorter follow-up. The number of cases, all told, of HIV infections is far lower in 084 that we've been able to characterize. So I wouldn't say that resistance wouldn't occur, but there is some bias in being able to characterize more of this in 083 because of the larger case number.
Okay, let's thank the first group. And Dr. Alsada will take over and introduce our next two speakers.
We have one last quick question here. I'm sorry, Mike. He's been standing at the microphone for 10 minutes.
Okay.
So
Go ahead.
Go ahead, please.
Yeah,
Sorry.
it's actually not a question, it's a quick comment. Yves Gephardt, Bayer Cornell Medicine Community GCAP and HPTN representative. I'm HIV positive and I'm so happy to see all those efforts that you all put in. Thank you everybody for your relentless efforts. I'd like to thank also the presenters who provide a community slide at the end of their presentation. I'm not a scientist, and that helps me and helps some of the other individuals as well, because not everybody knows what you talk about. So thank you all.
Yeah, that's a terrific suggestion. We'll make sure we do that next year. That's a really great suggestion.
Thank you.
Well,
Okay, Mike, we're all set. Rafa.
There's one more. I've been standing here.
Oh.
Yes, thank you. I just want to, my name is Nombe Kombongo. I'm from Desmond Tutu, Cape Town. I just want to emphasize that from the community understanding, I'm interested in the two presentations that we had today, but from the committee language, I had very little of what has been disseminated. It is interesting, and I would be very happy if we can get a very simplified version, not these slides, to the community, and they should be presented ASAP because we are busy mobilizing access for Cable A, so we need to be fully informed when we are communicating with communities at the ground level. Thank you.
Thank you very much.
Hi. The last one, please. I am from Porto Alegre. My name is Priscilla, and it's an important question for me, so I'm here. About the detection of acute HIV infection. So we can say that participants on cabotegravir PrEP should perform viral load in every visit as a standard of care. Or the second question is, it would be viral load would be a demand for the next studies with PrEP.
Can you repeat the I'm not sure I understand the question. You asked about the utility of RNA screening.
Okay. No. Yes, my question is participants that use cabotegravir PrEP should perform viral load as standard of care in the clinical after studies, and or the next question is, the next studies with cabotegravir or any other PrEP, we should perform viral load to guarantee the detection of acute HIV infection.
I think in each case you'll need to follow like study or local guidelines for diagnostics. The package insert in the US, FDA package insert, does indicate that viral load testing should be performed at each visit. That's recommended by the US CDC, but it's not in the WHO guidelines. And we are evaluating prospectively RNA screening at every visit for detection of infections in both trials. And the data on 083 will be presented in a late-breaking oral abstract at the AIDS meeting in July. I'll be talking extensively about HIV diagnostics on Tuesday in the Cabaret setting in the lab session as well.
Thank you. Thank you very much, Sue. And thanks, everyone. And I think I want to reiterate something that Monica touched on, which is certainly these long-acting agents, whether for treatment or for prevention, are profoundly effective and safe. And this science that we're identifying, digging deep into the science so we can optimize further the use of these agents. But I think we shouldn't lose track of the fact, at least for prevention, that long-acting cabotegravir is amazingly efficacious and also safe. So I think that's important to keep in mind. I want to just, this is our first day of our meeting, and we haven't had a chance to welcome everybody to the HPTN annual meeting. So I need to take a minute and just welcome all the people in this room. I think we have 500 people, I believe. Is that about right? 600 and 300 online, so everybody welcome. It's great to see everyone here together for our annual meeting, and we're looking forward to a terrific 3 days of very exciting sessions. Okay, so without further ado, let me introduce the next section of this session, and it's entitled Reaching Populations with High HIV Incidence and Limited Access to Services. And we have two speakers. I'll introduce them very briefly. The first is Ernest Museki. Ernest, say hello. And Ernest is a HPTN Community Working Group and Ethics Working Group member. And he has also been a member of the Community and Stakeholder Engagement Coordinator at the Botswana Harvard Health Partnerships in Gaborone, Botswana. And he's been involved in efforts around regulatory issues, as well as serving on the PrEP Technical Working Group in the Botswana Ministry of Health. And Ernest is joined with Marcrekus Harris, welcome. And Marcrekus is a deputy director of the Southern AIDS Coalition, and he's also proud to be the organization's longest serving employee. That's fantastic. And he has extensive background in clinical research, community-based organizations, state government, national affiliations, and is committed to working in our field. So I'd like to welcome both of them. Please welcome both of them to tell us about this important topic.
Do I need to do something to advance the slides, or does it happen? Well, good morning, and happy Father's Day to all the fathers here and online. My name is Ernest Museki, and I am with my co-presenter, Marcrekus Harris, and we would like to really thank you for giving us the opportunity to share with you best practices for engagement of populations and in high incidences and in limited settings. I must confess that I've got challenges with the eyesight, so I'm going to dip my head down to look at my notes. Do we have slides running?
I think you can do it.
I can do it. The green button?
Do you want me to advance them?
Please. You can go to slides number 2.
Number 2?
No, this one is fine. All right. We will provide brief background information regarding HIV incidence populations. We will also speak about health equity. We will share some success we have had in engaging Black MSM in southern United States and sex workers in Botswana. And of course, we will close off with a few final thoughts. Next. Allow me to provide a brief background on information on high incidence HIV incidence populations. Next. Well, high HIV incidence populations include sex workers, it includes men who have sex with other men, it includes transgender people, and people who inject drugs. HIV disproportionately affects these populations worldwide, and unfortunately, even in countries where the 95 target has been met or have been surpassed, we still see disproportionate incidence of HIV amongst these populations. UNAIDS tells us that approximately 70% of people who acquired HIV in 2021 was actually attributed to high incidence populations and their partners. Next. People from high incidence populations experience inequitable access to safe, effective, and quality HIV services, as well as disproportionate levels of, they experience disproportionate levels of stigma, of discrimination, of violence, of human rights violation, and criminalization. Several barriers prevent them from receiving the care they so much need, including police harassment, social discrimination, and insufficient supply of community-based services. In some instances, health services are misused as a means of punishment or coercion against high HIV incident populations, particularly for those whose behavior has been criminalized. As a result, people from high HIV incidence population cannot access the health care they need to address the disproportionate HIV burden they bear. I will now call upon my colleague, Madrikas Harris, to speak about importance of health equities for priority populations. Thank you.
Good morning, all. Thank you, Ernest, and again, thank you all for this opportunity. Let's make sure I know what I'm doing. There we go. So really quickly, there'll be information on the slides, but I'll give additional context to those slides. Okay, so in order to achieve health equity for priority populations, barriers to service access should be addressed through the provisions of client-centered, community-led programming. In order to provide HIV prevention, testing, and treatment services to high HIV incidence populations, differentiated services delivery models must be utilized, which provide services in a manner that support these populations without discrimination. Among the options available are drop-in medical centers, online outreach and case management services, and one-stop shops that offer testing and other services, as well as community-based treatment initiation and refills. The support provided to priority populations should incorporate strategies aimed at preventing and responding to violence, addressing stigma and discrimination, fostering enabling policies, promoting legal literacy, and sensitizing healthcare workers and ensuring competent care is provided. So in an effort to improve the healthcare access, HIV services provided in the communities are important ways to reach members of priority populations who are unlikely to seek HIV prevention or treatment at a facility, particularly those who are asymptomatic. To improve healthcare access, community-based healthcare should be made available in locations and settings acceptable and convenient to people from priority populations. I will repeat, they should be acceptable and convenient to the priority populations and the people that we're desiring to serve. Additionally, key populations should be offered testing and screening for not only HIV, but STIs, TB, and viral hepatitis. It is particularly beneficial to implement intensified TB case finding among key populations, since these populations in certain parts of the world are at high risk of contracting the disease, particularly in the countries who have high incidences of TB and HIV burden simultaneously. Equity also includes choice. So optimizing choice, there's a wide variety of personal preference. So HIV prevention and treatment options need to reflect this diversity. Various factors can affect preference, including timing, circumstances, life stages, and relationships. To optimize their function, utility, and scalability, these spaces where these choices will be offered will have to be tailored specifically such that spaces are inviting and non-stigmatizing for these key populations. Providing choices in this manner is the only way we can ensure that all people and all HIV exposures are adequately covered. Choice is very, very important. So to that end, HPTN has been at the forefront of developing and rigorously evaluating prevention strategies that have successfully transformed the HIV prevention landscape, including vertical transmission, U=U, and long-acting injectable PrEP. We continue to work closely with community partners, investigators, and other stakeholders to develop and test strategies that meet the unmet needs of high-incidence populations, including transgender people, young adults, adolescents, and people who inject drugs, men who have sex with other men, and cisgender men and women in East and Southern Africa. So for the next few moments, I want to focus a little bit on like black men who have sex with men in the United States, and we know MSM is a term that describes behavior and not an individual. I want to be clear about that. So I want to specifically focus on some work that we've done at the Southern AIDS Coalition. Some of it may be novel and some of it may not be, but we know what works, works. Okay, so as the Deputy Director of the Southern AIDS Coalition, I have the honor of being over our HIV programming and our grant funding opportunities for CBOs and local organizations. At the Southern AIDS Coalition, we've conducted a series of qualitative research to gain a better understanding of the barriers and facilitators that black men who have sex with men in the South face when attempting to access health care and other critical services. We use this information to create a needs assessment report that we have utilized for programming of health departments, service entities, and agencies across the Southern landscape. In an effort to address HIV stigma, we've done these things in ways where we can create various interventions that not only focus on people receiving services, but those who are also providing the services. So what we do with those focus groups is we gather the information. After gathering the information, we report back to the agencies that provide services to people. So you hear from the people who are receiving the services, needing the services, and then you take it back to the folks providing so that they know full well what people are desiring, what people need, and what people are saying. After those conversations, then we go and build trainings to build capacity for these organizations. And we want to help organizations create systems that are non-stigmatizing, culturally appropriate, culturally humble, and not just competent. And so additionally, after we do that, we conduct like 6-week interventions that help systems and audiences identify and understand stigma and how the different types of stigma show up. We have to focus on internal and external stigma. We also create these trainings additionally after those so providers see the holistic view of the people that they're serving and not just focusing on HIV status, whether positive, negative, or whether we want them to be on PrEP or whether we want them in a study. We kind of help providers see that holistic view because when a person feels that they are touched and cared for holistically, they're more prone to come back. They're more prone to be engaged in what it is that you are offering. So we work with CBOs to identify programmatic needs and fund opportunities to create interventions to address the needs identified by these priority populations. One of our other opportunities, we have grant-making opportunities to where communities know what they need. Communities know what stigma exists. Stigma exists different in different communities. The importance and the priorities of communities vary depending upon where you are. So we create grant opportunities for communities to be able to create stigma interventions in their area to combat stigma in the best ways necessary for them to do these things. And we do these, mostly we do it to a 2I approach. We do it intentionally and initially. We take the information to you initially before we roll it out. And then we are intentional all the way through so that we get you exactly what it is that you need and what you desire. That's the 2I approach. So Saving Ourselves Symposium, this picture is from a conference that we do. Saving Ourselves Symposium prioritizes Black LGBTQIA+ communities across the South, and it is our annual conference designed to educate and empower Black LGBTQIA+ communities. It is a one-of-a-kind conference that provides an opportunity for information exchange and capacity building for persons who receive services and persons who provide services to Black LGBTQIA+ folk. This conference gives a chance for for us to show cutting-edge research, what is happening in research among this particular community in the South, sharing promising health practices and strategies, and we also, in addition to asking you for information, in addition for sharing you what research is happening, we take time to intentionally celebrate the culture and creativity of the community in the South, so that it's not just about what we need from you, but we want to celebrate who you are, your existence, and the totality of who you are. Thank you. I also have the honor to serve on the HPTN 096 Community Advisory Group and have worked with the team to increase awareness of the study amongst the LGBTQIA+ community and organizations in the South through study presentations provided at this conference that we're speaking about, SOS, through direct engagement and on behalf of the study. Now I would like to turn the podium back over to my colleague Ernest, who will speak about his work with sex workers in Botswana. Thank you so very much.
Thank you, Rodriguez. Sex work is not illegal in Botswana. And I'm trying to look around to see if there's any sex work is not illegal in Botswana. However, there are certain aspects of activities that come with it that are criminalized, such as soliciting and keeping brothel. That is criminalized, and one can actually get convicted for that. Sex workers constantly face the threat of violence and endure numerous human rights violations. In Botswana, sometimes sex workers are taken out of the city where they operate to remote areas to exchange money for sex, only to be told that they're going to be left where the exchange took place if they do not pay the same equal amount of money that they solicited from the clients. What that means is that they provided the services, they did not get paid for it. That's how bad it gets. And sometimes there are violence acts that comes with it as well. Essentially, sex workers would perform a service and not get paid for it. However, we need to realize that there is a very strong sense of community among sex workers. This is evident in new and young people who come into sex work. The older ones actually take them through, they teach them how to do the business and how to look after themselves, which is really, really great. Our CRS has engaged with landlords. In order to avoid going to bushes, going to remote areas to exchange money for sex, they resort to renting rooms in the city or for a daily rate. And we've engaged with landlords of such rooms to ensure that there is a certain amount of safety at these premises. And landlords are on board and have actually come up with security protocols to ensure that there is presence of someone to mitigate any violent activity that might come out of the interactions with the clients. Next. Our CRS also work diligently to create a safe space and a welcoming space for sex workers. We train staff in effort to decrease instances of discrimination. We also implemented non-traditional service provision hours because time is money in sex work. If you keep them too long in the clinic, they might miss a whole day of work and therefore will not be able to bring anything home for that particular day. We also partnered with other service providers such as human rights organizations. We worked with law enforcement agencies who help us to empower sex workers so that they guard against any violent activities and so that they are able to access someone should a violent activity erupt. Next. Through the successful conduct of HPTN 084, the injectable carbohydrate study for people assigned female sex at birth, we were able to engage, we were able to recruit and retain sex workers in Botswana. The unfortunate thing is, just thinking aloud, is that studies are time-bound and the resources are very finite. However, this needs to continue. The engagement needs to continue. There's a lot of new information that comes from studies that sex workers can do with, that they need very much. And we need to have resources in place that will enable this engagement process to continue, because it should not be an activity, it should be a process, and it should live beyond the life of the study. Key to this success was ongoing engagement of sex workers, community, and CBOs who provides them with support, and integrated service to capitalize on the time that sex workers spend at the clinic. Sometimes we really need to think really long about individuals. Individuals might be integrations of comorbidities themselves, and coming up with integrated service would go a long way in actually assisting us, our participants, not just sex workers, but our participants in general. And it goes beyond just the physical, it goes beyond just the comorbidities. It also goes beyond into the space where these people live, the community within which they live. Because you might find that a sex worker is a mother, looks after children who also get sick and needs medical attention. You might find that a sex worker is actually a caregiver of somebody who needs constant medical attention. And we must think creatively as researchers of how do we make it easier and less burdensome for this person to come to the study clinic by providing an integrated health services. We know that that's not in the nature of research studies. Research studies are supposed to collect data to inform policies. However, we're dealing with human beings. We're dealing with people who are social organisms, and unfortunately, they have comorbidities. They have these other social issues that we really need to be thinking about as researchers. So we know that the research dollar is very finite, and I don't want to implore our PIs. I want to implore funders who might be in our midst to really think creatively. How do we ensure that we collect data, but at the same time we make it easier, less burdensome for our participants? Final thoughts as we close this session. Next slide. Access to healthcare must be improved to address the disproportionate HIV burden that high incidence populations bear. We must provide culturally responsive, community-based healthcare in locations that are safe and settings that are acceptable and convenient for priority populations. Sometimes calling people to the clinic doesn't really help, because our clinic might not be necessarily a safe space. They might not necessarily be convenient venue for our study participants. We might have to, think of putting a tent somewhere close to where the business occurs in order to make it easier for our participants to come into the study clinic. HIV treatment and prevention options should reflect the wide variety of personal preferences, as already said, and cultural diversity. Much has been accomplished, but the fight for health equity continues. We applaud all of you for your continued dedication in this fight, and thank you once again for the opportunity. Thank you.
So we do have time for questions, right, Mike? Right, Wafa?
Yes, we have time for a few questions. Joe. I see somebody at the podium here. Shall we start, Joe, on this end? Please, go ahead.
Please do.
Hi, good
Yes.
morning. Orlando Harris, UCSF. Dr. Mosiki, I just
Can
have
you
a
speak
quick...
up? Speak up.
Can you hear me now?
Yes.
Okay. I have a quick question for you. In Jamaica, my colleagues did a study there in a clinic where they found that they look at women and female sex workers and MSM who are living with HIV and accessing psychosocial services. And they realized that both female sex workers, women, and MSM are accessing psychosocial services like life support, food, all those different things. But MSM tend to reach viral suppression a lot faster than women and female sex workers. And the thought behind that was because they have other competing priorities, childcare, taking care of the home, etc. And I'm wondering, from work that you have done and what you've seen in terms of the needs of not just female sex workers, yes, but they're also probably parents or a parent or taking care of their family. And I'm just curious in terms of what you've seen in terms of achieving viral suppression among that particular population in the presence of life.
Thank you. Maybe you can comment, please, Ernest. Yeah.
Yeah, thank you for that brilliant question and observation. Social support is critical for viral suppressions. And this we've seen with the work that is done by community-based organizations that work with sex workers in particular. They have developed a sense of sisterhood, and that is primarily because the organization was founded by sex workers themselves, and therefore there's a lot of ownership. However, they've got technical people working with as staff and have really helped them in terms of adherence to treatment, adherence to doctor's appointments. And of course, that goes beyond just the individual that you see in front of you as a sex worker, but also they're encouraged to, and they are able to also bring in their children. They're able to bring in some instances, their partners, who are then talked to about the importance of adherence for reaching viral suppression.
Thank you very much. Hand it over to Joe. A question from you.
Yeah, we have a question here. Please identify yourself. Thank you for coming to the microphone.
Good morning. My name is Baraidi Winnie Sintu from Botswana. I also sit in the CSS subcommittee of the ACTG. Not a question, but a comment and an appreciation, just to appreciate the works that the networks are doing, and also appreciate the connectivity between the networks. Throughout the week, as representing the community, I have, of course, observed very promising interventions. Just to thank our researchers for their aggressiveness in continuing to find novel interventions with the aim of finding better solutions. What is promising for the community is the obvious and growing efforts in ensuring that behavioral and social research is incorporated in research, as well as ensuring efforts to ensure that different segments of the communities are thought of as we develop research protocols. This will surely help answer questions as to what works may not necessarily work, because it will bring us to understanding human behavior, community behavior, and factors surrounding issues of adherence and just uptake of different interventions. So we really see it as promising from the community point of view. I just wanted to appreciate that, as well as efforts to ensure that capacity building is part of the whole process, especially targeting the communities as well. We've seen what Hank and other bodies are doing. So we really want to appreciate that and say, it ensures that the partnership is really alive. Thank you so much.
Thank you. Appreciate your comments. Thank you very much. I have a question here. Please, go ahead.
Hi, Fred Mazik from Boston Family, NABS in 7. My question is for you two gentlemen. Can you kindly talk about the relationship or the similarities between Southern Africa and the southern states in USA? I grew up in South Carolina. I still have family there, and it's bad. HIV prevalence is bad in South Carolina. Can you just briefly touch on how the two are similar and what approaches could work for both?
Thank you.
So I will, thank you, start, and mine is going to be a very simple response. The initial commonality is the desire to end the HIV epidemic. It's also, when we talk about incidence rate, the southern U.S. leads in many of the categories as it pertains to HIV, whether that is incidence, trying to maintain viral suppression, getting people access to care. And while we have lots of things that people could access, there are still barriers to access. The hierarchy of need of an individual should still be prioritized. And sometimes we get so focused on the desire to get folks in care, the desire to progress a study, to progress a program, that we neglect the hierarchy of needs. So I think that need-based is where there are similarities. And then stigma. Stigma, I think, is all over the place. People not wanting to access services, not wanting to be in studies, not wanting to go into certain facilities because of the stigma that's attached. And that stigma is internal as well as external. And so those would be the simple responses to those similarities, and I will pass it to Ernest to respond as well.
Thank you for the question. A very interesting question indeed. Similarities and what could work in both settings. Mr. Harris said it all in terms of stigma, but we're also seeing that the priority populations are similar in the sense that they still have inequities, especially when it comes to accessing healthcare that is appropriate, healthcare that is culturally sensitive, and healthcare that is accessible. And it works for both. It's apparent in both communities. And the other thing that is also apparent is disproportionate HIV incidence amongst the two. And I don't know for real what could really work in both settings, because we are world apart, and we sort of have different access. We access resources differently. But I really appreciate what your question, and it should not just be our question, but it should be questions of everybody in this room, and online, just to think about how then, what could actually work here in the US, in southern US, as well as in sub-Saharan Africa. Thank you.
Yeah, and I think being here at this annual meeting and coming together like this is the right opportunity to learn from each other what works, what doesn't work, because I think one of the best things is to take home some of these collective learnings. So thank you for the question. Joe?
Yep, so go ahead, on the microphone on the left.
Okay, good morning. I'm Rosalind Swartz from Cape Town, South Africa. Also a CSS member at the ACTG. Thank you for Ernest. I met him this morning on screen for the first time, and I want to thank ACTG to give us the opportunity to meet the HPTN people so that we can, on this platform, it's so sad to meet each other on this platform and not back home. My question is, how can all communities in our countries, districts, places have access to the prevention matters that, you know, both ACTG and HPTN work very hard on, but certain communities in our countries, places, don't have access. With the research day, good day to my colleague from Desmond Tutu. With the research day, I had an invitation to Desmond Tutu's research day, and I invite a colleague, and she was really shocked to hear about PrEP, to hear about the viral ring and other certain prevention methods. You know, the district that I worked in, the Mitchells Plain district, is the biggest district in the metro, Cape Town metro. I'm also the chairperson for the civil society sector, which I work in all 6 districts in our metro. And it's really sad to tell on this platform this morning, especially our youth between 14 and 25, where the new infection, on every outreach, there's a new infection, even if it's one. Don't know about this prevention methods. And I really want to thank my CSA, the ACTG, to give me in this past 6 years opportunities, trainings, learnings, everything that I can be able to roll out in my communities.
Thank you very much for your comment. Very much appreciated, and certainly your comments energize us to do a lot more to be able to bring the tools and methods to as broad a population as possible. Thank you. We have the last, I'll take one last question on this end, Joe, and then maybe one last one from your end. Please, somebody's been standing there for a long time.
Thank you so much. My name is Diana Namombeja Aboye. I'm from Yale University. I want to make a comment about HIV and mobility, maybe a comment as well as a question, but we'll see. Currently, we are having a lot of global movement, migration, due to a lot of unrest. And how do we ensure equitable access for prevention and treatment to refugees, particularly those in transition, living in airports in so many countries, in multiple settlement centers? How do we provide what you have termed as acceptable, equitable care for these populations, given what they are going through, what their histories are, but yet they are still there living their lives as any of us would and having the same risks? So I want us to think about that, and hopefully if someone has a response, I would really appreciate. Thank you.
Thank you. Ernest, you want to take that about migrants and refugees and services?
Yeah, you know, in the past recent, we have seen unprecedented number of people moving from one place to another due to this or that reason. In some settings, there are organizations that work with refugees in particular. However, I haven't really heard of any who works with those who are on transit, and I would throw this question back to the group, to the team, to actually think about what is available for refugees generally, but what in particular, what is available for those that are on transit, because they are in a much dire need than those who are actually in centers, and they need healthcare, they need pre-exposure prophylaxis like yesterday.
Thank you very much, and maybe this can inspire us to think of maybe next year having a session that focuses on this population in particular. Okay, I'll hand it over to you, Joe, for the last question.
We have one last question. It really does need to be quick, though, because we have to be somewhere at 11.
Okay, thank you. So my name is Andron Nizitic. I'm a technical director for innovation and special projects at the Aurum Institute. I'm a professional industrial designer. My journey started, this is going to be a challenge to both organizations. My journey started in 2000 at the AIDS Congress in Durban. I was the designer of the Glaxo Welcome exhibition stand. 24 years later, I'm sitting in this audience and I'm fascinated by what the science has achieved. But as I listen, I hear more and more user-centeredness, participant-focused, client-focused, adherence, looking at user-centeredness again. And I'm realizing that the role of design and design thinking should be integrated into your future solutions. I had a role in 2000 and I used that design thinking, process engineering at the Aurum Institute. And I think that's the gap that you're missing. And I think that's the challenge to you is this goes beyond science at this stage. Thank you.
Great, thank you very much for that comment. Very, 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 very thoughtful. So really, this was a terrific session. We love that the PTN and ACTG has gotten together, and when we have overlapping meetings in the future, we should make this a priority. So thank everyone over at the JW Marriott. Thanks for being here, and we appreciate you.
Thank you from this end as well. So at this point, we have a break, a coffee break, and then we all should get back together. I would say 11:15. Is that okay? Okay. I'm sorry, I have the wrong hour. Yeah, in about at 11:15 or so. And I just want to inspire you all to please come back here, because we're going to have the always highly anticipated HPTN Scholars Plenary. You're going to hear from our young investigators, our young scholars. So please have your coffee and bring it back in for the next session. Thank you.